name is Suzie Bash. I'm a neuroradiologist at RadNet. Today, I'd like to talk to you about the value of quantitative MRI in evaluating patients with multiple sclerosis. We actually use qMRI for a lot of different clinical indications, including for dementia, multiple sclerosis, epilepsy, pediatrics, traumatic brain injury, oncology, and vascular disease. This is what segmentation typically looks like throughout the cortex and pertinent substructures of the brain. But in particular, with multiple sclerosis, we'll see segmentation of the actual disease burden, so the plaques throughout the brain. Often, when a patient comes in with multiple sclerosis, their clinical symptoms may be slightly ambiguous, and it's often on MRI that the first diagnosis is made. It's at that time we would like to encourage the use of quantitative post-processing, like NeuroQuant MS. And then if there does remain clinical ambiguity, you could always do CSF analysis to look for oligoclonal bands. But typically, the diagnosis can be made right off the MRI. The qMRI segments the plaques throughout the brain and also categorizes them according to their location. So you see here, red is juxtacortical, purple is periventricular, orange is infratentorial, and yellow deep white matter. But most importantly, the software detects which plaques are enlarging or are new and which plaques are shrinking in size versus stable. So this is extremely important. Neurologists very much care about the longitudinal analysis of their patients because there are a lot of good disease modifying therapies out there. And if there are a lot of new or enlarging plaques, the neurologist will typically switch therapy for the patient. So they're really relying on the radiologist to give an accurate interpretation. And you can see here, this is the type of image that you'd see on your PACS, where enlarging plaques are yellowish, new plaques are red, and shrinking plaques are blue. And you can see how this really stands out. It's very difficult when you have differences in slice sampling or head angulation to detect which plaques might be changing since the prior study. Particularly when a patient has sort of a moderate or moderately severe or even severe plaque burden. This is what a NeuroQuant MS report looks like, and we'll mag up a little bit here so you can see a better view. But basically, it allows the current lesion burden, so that's the plaque burden in volume. So in this case, this patient had 6.95 milliliters of plaque, and then it gives you the prior plaque burden as well. So previously was 4.57 milliliters. And then it also tells you where those plaques are located. In addition, it gives the lesion count on both the current and the prior study, and also gives the lesion load by percentage of white matter involvement. And then importantly, it gives the lesion dynamics. So we see here the count and the volume of new, enlarging, shrinking, or stable plaques, and also the location of the dynamic change since the prior exam. This is the second page of the NeuroQuant MS report, and it actually just gives more detail here about lesion burden by location and also by hemisphere, so you can get an idea of whether the plaque burden is symmetric or asymmetric. And then we have a plot graph that that describes more the lesion history over time, so you can get a nice visualization from the current to the prior study. And then these are more reference charts here with plot graphs. The current study is in black and the prior study is a gray trail graphs here. So you can see how the brain volumes are changing over time. And then most importantly, it gives a pre-populated reporting template that gives the overall summary of the MS report. So again, it tells you over the past, in this example, since 13 months since the prior study, what that change in the total plaque burden is, what the volume of enlarging plaques are, and mentions here that there was one new lesion in the volume of that new lesion. And then it gives the whole brain volume and also the gray matter volume as well. And by the way, the report also can generate white matter volume as well. So this pre-populated reporting template is very important. You can use it if you want to. You don't have to use it if you don't want to. And then this can also be auto-generated into your PowerScribe directly, or can be copy and pasted and placed into your report on PowerScribe or whatever dictating system that you're using. Now, I do want to mention that evaluation for multiple sclerosis has changed over time. And as the software versions have progressed over time, the accuracy of segmentation has significantly improved. So we tend to use a 3D FLAIR input, and that is encouraged, although it will process off a 2D FLAIR input as well. But you can see here in older versions of the software where only machine learning was utilized, these two small plaques in the pons were initially missed. But with the more current versions, version 4.0 and beyond, we're now at 5.1, it's actually an incorporation of both machine learning, which, by the way, does a great job in filling out plaques in the periventricular region, but also now deep learning, which does a wonderful job with juxtacortical plaques and infratentorial plaques. And so you can see here that these two plaques in the pons have now been detected with the newer versions of the software. So when you're reading a case with quantitative post-processing, the prior case is also processed through the newest version of the software. So again, you would have your technologist push the prior study first, wait a couple minutes, and then push the new study over the cloud to Cortex for post-processing. And then as these are stored in the database, the prior studies won't need to be pushed because they already will be processed in the database automatically. So your current report will incorporate both the current study and the prior study. And again, really, really excellent segmentation in these newer software versions. Using QMRI can also improve the detection of disease activity. In this particular study, actually, if you didn't use the QMRI software, the neuroradiologist thought that there was disease activity, meaning newer enlarging plaques, in 24% of the cases. But when you actually use quantitative post-processing, that percentage jumped all the way up to 76%. And this is a big reason why our referrers, once they start using this, will never go back because it is very important for them to know if the patient has active disease because, again, they will modify the medication if that's the case. Now, it also improves the reliability of reading. So 22% improvement in intra-reader variability of the lesion count when the software is used, and 23% improvement of inter-reader variability of lesion count when the software is utilized. And again, that's very important because most neuroradiologists work on an RVU basis, and it's really important to dictate as many cases as possible. And so there's a tendency to call these cases stable, 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 when really there may actually be progression. It also can enhance productivity. So in this particular study, the neuroradiologist was able to read 38% more reports per hour when they used QMRI and the pre-populated reporting template. So they could basically dictate 8 MS cases an hour without the software and 13 cases an hour with the software. Again, very important to know given the time pressures on neuroradiologists these days. We actually have noticed a large increase in our NeuroQuant volume at my particular imaging enterprise, 103% increase over the past year alone. And again, a big proportion of these are in MS and in dementia. We do have, this is a look at our ordering form here. We do have a separate click box for quantitative volumetric imaging, and then you can just have the referrer click which kind of protocol they want. So in this case, an MS protocol, and this makes this very easy for everyone involved so that they know that that they're interested in doing QMRI. Now, new CPT Category 3 codes came into effect on January 1st, 2024. It's very important to bill under these new CPT codes. They are vendor neutral. It's really important for a couple of reasons, but one of the reasons is we'd like to see conversion of the CPT-3 code to CPT-1. CPT-3 is a tracking code. Having said that, we are starting to see reimbursement, which is wonderful news. We're getting about $231 every time a QMRI study is ordered. And again, it doesn't matter if it's multiple sclerosis or for dementia or pediatrics or traumatic brain injury, but in general, this is what we're getting back from the MACs, the Medicare Administrative Contractors, in the 12 westernmost states of the U.S. And we hope here that the rest of the states will follow. We are petitioning the MACs throughout the country, and typically once some start reimbursing, others will as well, and then private payers follow. So that is really exciting news. And so overall for NeuroQuant MS, we see that it really does improve diagnostic value. It significantly decreases reader subjectivity, negligible cost to the acquisition speed. Again, the inputs that you would use is your FLAIR input and your 3D T1. There's no radiology post-processing. It's very easy to interpret. It improves efficiency, and also it's a good return on investment now that we are getting reimbursement for these. And it offers an excellent referral advantage. Thank you so much for taking the time to join us.